Hello and welcome to Incorruptible Mass. Our mission here is to help you transform state politics. We know that together we can make Massachusetts policy reflect the needs of the vast majority of the residents of our beautiful state. And today we are talking about an article that describes the terrible state of primary care healthcare in Massachusetts. This is the fourth of our 4-episode deep dive into healthcare topics. Today, we're talking about what's happening at the state level and the fact that it is getting increasingly difficult to access any primary care. But before we do, let me have my fantabulous co-hosts introduce themselves. And today, I will start with Jonathan.
Hello, I'm Jonathan Cohn, he, him, his. I've been active on progressive issue and electoral campaigns here in Boston for over a decade now. And to throw in, because we're on the podcast, there's one joke I had just made the other day when I was saying about how Governor Gavin Newsom and I actually have a lot in common. We're both white men, we're both Libras, we both have podcasts, and neither of us will ever be U.S. president.
Amazing. And Jonathan, I'm not counting you out.
I appreciate it.
And Jordan.
How do I go to that? Jordan Powers. I have several years experience in politics in Massachusetts. Yes, I guess I'll never appear on Gavin Newsom's podcast because I'm black.
And you're not right wing.
Yeah. Well, it seems that right. That might be some overlap, some Venn diagram overlap on those things, but not total circles, but you know.
That's right. I am Anna Callahan, she, her, coming at you from Medford. Particularly interested in local elections across the nation and how we can reinvigorate democracy from the bottom up. But I am also a city councilor in Medford, and just love that I get to work with these amazing people on the podcast every week or two, and really excited to close out our conversation about healthcare with this one that is specific to Massachusetts. So we will put this link below, but it is to an article of some research that was done, and it is called A Dire Diagnosis: The Declining Health of Primary Care in Massachusetts and the Urgent Need for Action. So, man, lots to say about this article. Does anybody want to, I can give an overview, but if anybody wants to jump in with their favorite points in it, I will first talk about how basically what they're saying is that there are far fewer. So healthcare in other states and across the country, primary care providers are growing in number, but in Massachusetts, that is just not happening. It is getting increasingly difficult for people to access primary care. I think my bullet point that I thought was really the one that got me right here was where it says roughly 40% of emergency department visits continue to be those where a patient's condition could have been treated in a primary care setting or prevented with timely primary care. This is in Massachusetts. And that is people who, and in Massachusetts, remember that we have one of the highest rates of people being insured, right? So people are, I understand, I do this, lots of people do this. They do, they hesitate to go to the doctor, but it's not anywhere near as bad as in other states. So why would it be that in Massachusetts, where we actually have higher rates of insurance, that 40% of our, emergency visits are people who could have been seen in primary care, and it's because they cannot access primary care, even if they are ready to go there, they're not able to.
Yeah, I'll just say I think this, one of the things I took away is the way of all the interlocking systems of failure, and how much the other conversations we're having and had about the healthcare system really becomes acute when you talk about primary care. You really see it when you talk about primary care. So they're burdened by the administrative state. What is the administrative state? It's private insurance making you jump through hoops to get the care you think would make your patients healthy. So they're burnt out by having to argue with insurance people about the care that they want to give to you to help keep you healthy. It's not as in this directly, but there's been some other reports. It's really expensive to live here. Often primary care doctors have high debt. because we also underfund higher education and public education. So they are looking for places that might be more affordable to do this work, especially if you're in primary care. So you have like, it costs a lot to live here. It costs a lot to buy a house here. You have a lot of debt because of the broken and ways in which we're not funding these things. And then you're really, you have a lot of burden from all of the insurance that doesn't make any sense whatsoever. And then to top all of it off, you're incentivized because of the ways in which our system has been privatized to do other types of doctoring,
Right.
that makes more money. Because primary care is general care. It's the best type of thing, which is you get to know your patient and then help them as best you can. But if they need specialized care, that's where the money is. That's where you pay off your student loans. That's where you get the really expensive car. And so because of our for-profit system that privileges hospitals and lots of tests and things that run up costs but don't make a lot of sense, our primary care people are not encouraged to go into those fields. So the pipeline is sort of broken. So it's like all of the problems summarized into the most important part of the care.
Just reminded me of it's a separate field to medical care, but that issue you're just noting with how it incentivizes people to go into become a specialist as opposed to primary care doctors reminds me of in the legal world where everybody is, because of like the debt from getting a law degree, you are incentivized to become a corporate lawyer. And so that we produce quite a lot of people whose job is to help corporations become richer, much more than we do producing people who are trying to make the world a better place.
Yep. And
so,
yeah, go ahead.
Yeah, I would say just some other highlights for people who are interested in this. Of course, people who struggle the most are kids are really struggling in this, especially kids from low-income families. So, you're more likely to have no primary care visits if you're a kid coming from a low-income family, but kids are also getting delays in getting the sort of care that they want. 41% of Massachusetts residents have had trouble getting a primary care visit. I know myself, I went a year and a half in between my annual, not because I didn't ask for it, but because my primary care did not have space to things. And she recently, my primary care doctor recently is decreasing the amount of hours because she's burnt out. And was like, I'm sorry, Jordan, like I'm if you want to stay with me or go to a different person, but I'm going to be doing less days. So like, just, again, these are things I think we're all experiencing, but they're real problems.
Yeah. Same with us. So my sons, your kids, they go every year, right? They go around their birthday, but of course insurance doesn't say they can go every year. Insurance says they can go 365 days after their last visit, which means if you miss it for any reason, you're set 2 weeks later, then that is 2 weeks later. We happen to, because of things going on in our life, we happen to kind of forget to set it up. And then when I called around his birthday, they gave me a date that was 5 months out, 5 months away. And that just means that now, basically, at some point he'll be missing a yearly visit, right? Because that's 5 months out. And then it happens twice. And basically you've missed a yearly visit for your child, right? This is not what we should be doing for children in Massachusetts.
And I think the one thing that's really underscored by these issues around access that the report highlights of people having difficulty in accessing primary care is that getting a condition that Massachusetts largely has where most people have insurance of some kind. And we've talked about the problems with in other episodes of our model of health insurance, that having insurance doesn't mean you actually have the ability to use the care you are being insured for. And that they're fundamentally different. And they're different things, which is why you might be covered, but if you have insurance that will cover an appointment that you can never find somebody to book you for, it's ultimately theoretical that you have coverage.
Yeah, I mean, it's the difference between coverage and care, right? You're not exactly. It's theoretical. Coverage is not actually leading to care. It's just a theoretical care, but it's not the thing. And so
if you get the care, you won't. But but not that you inherently do. But sorry,
And
go on.
importantly, coverage involves you paying the insurance companies.
Right.
Yeah.
Right.
That's
Right,
why they've got to make sure we've all got coverage. But care is you getting the care, right? They
Yeah.
don't want
Right.
that. They
And
want
then
the
it's just-
coverage part.
Right. They're not doing as much to make sure that that happens. Yeah.
Exactly.
Through incentives, through other things. And, if you think about it, I mean, the other pieces too, that other studies have shown is that the amount of time that primary care doctors get to spend with you has decreased, right? So the purpose of primary care is that they get to know you. They get to know your health. They get to know something about you. They get to spend more time with you. So because we're invisible to the system, right? They can't peer through your skin to see what's wrong. They have to sense it. They have to get it through clues, through your data, through your blood, right? They need lots of information. The more information they have, the better your care is going to be.
And
So
do what you say. You have to be able to talk to them. You have to have time to talk to them.
Right.
Mhm.
Right. When the standard is once a year, which is too few times to see a doctor to really get a sense of you, it should probably be more, twice, I don't know, whatever. And you have less time with that person because either the system that doctor is in is forcing them to spend less time, or they themselves don't have time because they're constantly having to bill out that time with insurance. And if they spend more than 6 minutes with you, they can't bill that time. Whatever it is, there's just the economics around this are geared towards you not getting care, but insurance getting paid, and other people getting paid. Right. So the important, to your point, Anna, the point of the system is for rich people to get their money, but not for you to get care.
Right. Exactly. I also want to bring up my experience with my mom. So my mom, who passed away last June, bless her. I took her to her doctor's appointment when she was 86, so a year before. And I was flabbergasted. We were there for like 2 hours. This is a primary care visit. This wasn't a sick visit. She went there and she talked to her own doctor for probably an hour.
Wow.
An hour. And I was right there in the room. I've never seen that in my life. I get the, 10 minutes or maybe 15 if I'm lucky with the actual doctor, and I think Medicare, obviously she's older and I'm sure those are a little bit different, but Medicare has an understanding that is what is needed at that age. But we don't have any sort of a one payer system like that, and so nobody wants to do anything. They don't want to fund the doctors barely talking to us at all. Why should they talk to us? It's better if we get sick because then they get to make more money off us.
Yeah. And I'll just say again that this study isn't from Lefty McLefterson. This is right. These are a dire diagnosis is from the Massachusetts Health Policy Commission. So imagine what it takes for bureaucrats who would never talk poorly about insurance to say y'all, this is a crisis. They use the word crisis, not us. They use that word. That's how I just cannot stress to you how much of a 5-alarm fire this is and how little coverage it got. This should be something that we all the government should understand it's a big deal, like housing. We should be not that they're addressing housing because they're not, but
yeah.
No, we should understand that this is a to our foundation problem, and instead it's one article.
Yeah. And that article, don't forget the title. It starts off with a dire diagnosis and ends with the urgent need for action, right? They're not pulling their punches here. No. And by the way, can we have Lefty McLefterson on the show?
I know, I was thinking the same thing. I was like, Lefty McLefterson sounds Irish. I wonder what town in Ireland the Lefty McLefterson's family comes from.
I think the O's are Irish and the Mcs are Scottish. Am I wrong?
I don't know.
Mc is Scottish. O is Irish.
Oh no! I thought Mac. I thought Mac was Scottish and Mick was Irish.
Oh, could be.
I think that sounds right, but also I don't know.
Lefty we'd have to have Lefty McLefterson on the show to
tell us for sure
Lefty McLefterson
Lefty of
European and a European mutt.
Yeah,
there you go.
Yeah, what country of origin are they?
Well, I wanted to just bring up a little bit there. So linked this article on that and a Commonwealth Beacon article were linked to each other, and I wanted to bring up that article because this other article is about some legislation that probably won't pass. Of course, we're in Massachusetts. Who are we kidding? But like I really loved what they were talking about in this legislation. I just want to kind of read what some of this legislation, might have in it that we could push for. And it says it includes policy changes like doubling state investments in primary care, allowing practices to opt in to make primary care free for patients, and get this one, replacing fee-for-service provider models with one lump sum per patient per month. That is sounding like
Single payer.
Single payer. Right? They're not phrasing it like single payer. They're like, oh, we're just gonna word it differently. Let's make it not sound like single payer. We're gonna go, oh, just a lump sum.
Yeah, maybe we should whisper it.
Yeah, whisper it. Exactly. Maybe we'll say another language, like say it in Italian or something,
Yeah. It's lump sum.
Lump sum. Maybe we can get it through,
Right.
lump sum thing. They'll like the idea of lump sum, right?
Yeah, exactly.
Call it lump sum coverage LSC. Just talking about wonky terms. We're not talking about the other policy you heard of. This is a specific thing.
Yeah.
This reminds me of like I was talking to one of my to my nephew and he's like in his 20s, and we were talking about how do we write a journal article that like really markets this amazing carbon sequestration device that is like incredible and all the scientific things about it, and use all this wonky terminology and blah blah blah. And of course, at the end, it's a tree.
Yeah.
Yeah, a photosynthetic.
Exactly.
Carbon sequestration.
Yep.
Low cost.
Yes, low cost carbon
Low
sequestration
cost
has been field tested for thousands of years.
Oh,
photosynthetic dendritic pillars.
I love that.
I gotta say, my mom was very funny, and she used to joke about how when she was having kids and stuff in the 60s and 70s, the doctors would tell her how amazing and wonderful formula was, and how it was lab tested for N years, and had all these studies and whatever. My mom, who didn't say it out loud to them, but was like, yeah, well, breast milk has been field tested for millions of years.
I was just looking at stuff from the Commonwealth article as well, and one thing that's kind of like another shocking statistic on this report is the kind of notes about how old the primary care workforce is in Massachusetts, with a third of primary care physicians being over 60 years old and heading to retirement.
Oof. Wow.
And so you have kind of a situation where the people in the field are disproportionately on the older end of the spectrum of doctors, and so that if you have some of the younger ones are getting burnt out,
oh yeah,
it risks creating this like, as noted, where it can get to a crisis point where you're not replenishing that base of the workforce, creating like terrible like downward spirals in excess when no people get in and those who go in don't stay.
And I will also say that like my sister's a doctor, and we would talk during COVID, and people may not realize, but because people were not coming in for elective things to the doctor, they weren't coming in when they had a cold, right? They like, they would come in if they thought it was COVID, maybe, but people were terrified, and so practices and hospitals, they were just firing people left and right. They were firing nurses, they were firing doctors, they were firing administrators. Like during a pandemic, during the worst health crisis that we had seen in 100 years, our medical industry shrank. Our ability to provide medical care for people shrank drastically. And they note in the article that, let me find the quote where it says COVID, but they talk about how they have not grown since COVID levels. Like we have, unfortunately, really not grown our primary care since COVID levels. And that's what people don't understand is COVID levels were like very low because they fired tons of people.
Right. I thought the thing you were going to say is that, like, because one of my best friends is a doctor, and they're all thinking about how to leave.
Oh,
Like,
yeah.
they're burnt out at my age in their
Yep.
40s.
Yep.
They're like, they're because again of insurance, of the administration, the administrative states. I have a friend. I guess I should say where they work, but they work in a place that's supposed to be patient centered, and it got taken over. It was run by as soon as it got run by a corporate CEO as opposed to a doctor, all of these doctors want to quit because they're making decisions that are based on accounting and not based on the health of the patients or what's good for people. And so there's all this pressure to do things that are actually unsafe because it's being done by somebody who has no degree and no doctor degree, but is looking at it from a corporate CEO perspective. And so which I always tell people, like, is actually just a glorified accountant, because we think of them as people who build businesses, but they don't build businesses. They've never they've never built a business, and they don't know how to build a business. They know how to cut money.
Right.
They see the X's and O's. If they knew how to build businesses, they wouldn't make the decisions they make. But anyway, I digress. But so like, also there's just the downward pressure, because this system is toxic to the people in it. It's like bad. Like, we always talk about the bad health outcomes for us. We should care about that, but it's actually really bad for the people in it. They know it's
the physicians, the nurses, the administrators too. It's terrible.
Right. They don't like this system.
Right.
They don't like spending 6 minutes with you. They want to spend an hour with you. And then they feel pressure to give you drugs because you want a quick fix, or they don't have enough time with you, and they don't have a rapport with you, so the advice they might be giving you feels like offhanded because you don't know them, they don't know you.
And there's so many commercials for drugs. People actually come in wanting drugs, which used to be illegal, by the way. That used to not be legal to advertise, prescription drugs on television.
Bill Clinton made that possible. So I mean, like, all of those things, like this, just remember that's toxic for them. They don't like this system either. And so there's also that pressure. Like, also people are leaving earlier. They're leaving as soon as they can. My friend says that every doctor she knows can tell you what their payoff for their medical degree is, so that they can leave when they're done paying off their loans.
And on a side note, that stuff is crazy, right?
Yeah.
It's like, especially in primary care, it's like 10 years, 15 years.
15 years.
Yeah.
Not more.
Yeah. You think that, like, doctors are paid well, and that's why it's worth it to go to medical school. But, like, and it's 15 years. And when you say 15 years, you're talking about starting off with residency, where you're doing 12-hour shifts,
Yep.
like sleeping at the office, like, God forbid you have children. I mean, it is.
Yep.
And you have to go wherever they send you.
Right.
One person told me that, like, if they did not accept the place that they were sent, they would not be a doctor, and all the money they spent on their medical degree would be burned up.
Yeah. Well, I feel like that's a good point as well with, like, the 12-hour shifts. It speaks to the problem of just in general in the way of staffing the healthcare sector, is that, like, we know that when people don't sleep, brain function goes down. Yet rather than just simply, like, hiring more people, the system typically operates on the basis of having people work very long hours with minimal breaks, sometimes in between.
Yep. Right. And then again,
and making very, like, complex, very, like important, high risk, complex decisions. and
then the problem is then that we get frustrated, and then the point of contact is these people.
Yeah.
Right. So they're maybe they're making the best decision, but maybe not the best they would make if they had 8 hours on the job instead of 12. Mm-hmm. And you're frustrated, or you come back because something bad happened because somebody made a decision, and now you're back there and that person's getting it, right? It's just, this system is bad for people. It is bad for people. Every person in it. It is failing every person in it. And the primary care is acute because it's the most important and the least paid.
Yep. Surprise, surprise.
Yeah, except for maybe nursing, which we could talk about that too, the same problems.
Yeah. Yep. Well, there you have it. Anything else to say about healthcare in Massachusetts? We're, like, going off of a cliff.
Other than that, it's doing great.
That is doing awesome. It's just like, everything we could say about the Trump presidency. Well, like everything is going to hell in a handbasket, aside from that.
Right. Other than that, Mrs. Lincoln.
Yeah.
Oh my goodness. We do hope that you guys have enjoyed our deep dive. And I will say our next deep dive, we're very excited. We already have like 3 fantastic guests lined up. We are going to be talking about immigration. We'll be talking about it at the national level. We'll be talking about it at the state level. We'll be talking about, very specifically how the Trump administration is affecting immigrants in this country. So we hope you'll join us for that. Final words from the peanut gallery here on healthcare in America.
Be kind to your primary care doctor. Even if you're frustrated with them, be kind.
Totally. My final words are Medicare for all.
Yeah.
With your frustrations to your elected officials.
Yeah.
Voice your frustrations to your elected officials.
Yeah, totally.
Yeah.
Why do we not have Medicare for all in Massachusetts? No reason.
You can't see us. Yeah. We're all shaking our heads.
We're all shaking our heads. All right, gang. Thank you so much. We look forward to chatting with you all next week.
Hey there. Thanks so much for watching us on YouTube. Please like and subscribe. And it would be amazing if you would also subscribe to us on your favorite podcast player. Just look for Incorruptible Massachusetts wherever you listen to podcasts. Thanks so much.